Hi, class. This is Dr. Weaver again, and I am recording the second um, video of this PowerPoint presentation regarding abdominal assessments. By this time, of course, or perhaps when you guys would have started listening to this one, hopefully we would have already gone through, I believe, slides 1 through 24 in class. So let me go ahead and get started because I think there is 50 slides altogether. Um, and so I don't want to make this too long. Um, so let's go ahead and start this process. Let me go ahead and start sharing my desktop. All right, and hopefully you can see that. All right. So the information on this particular slide is on page 541. And this is in regards to vowel sounds. We always have to note the character and the frequency of vowel sounds whenever we are assessing our patients, um, especially when these patients come from surgery or post surgery. We have to do this, GI surgery in particular. But even throughout your routine assessments, this is something that is very important. And we'll talk about some of the things that, some of the language rather that we use, and also some of the procedures we use in terms of assessing our patients. So you guys have heard of vowel sounds, of course, and we have to think about where these vowel sounds originate. There was a time many years ago, at least, I thought that they came from the stomach. Really early on in my career, but they actually come from the small intestine. It is due to a combination of air and fluids moving through the small intestines, is what you're actually listening to or hearing. When we hear vowel sounds, they are sometimes high pitched. Um, there may be gurgling sounds, cascading sounds, one sound after another, and they also are irregular, which can be normal, irregular um, vowel sounds, and they may be heard anywhere from 5 minutes to 30 minutes, 5 to 30 times per minute. Um, when we describe the character of the vowel sounds, we may either hear hypoactive vowel sounds as well as hyperactive vowel sounds. We can also hear, obviously, normal vowel sounds. Um, but the abnormal vowel sounds would be um, your decreased. Hypoactive vowel sounds are decreased, and they can follow a surgery, or if there's any kind of inflammation, such as peritonitis. There's also hyperactive vowel sounds, and these sounds are loud. They are high pitched, and what they tell us is that there's increased intestinal motility. All right, the small intestines are moving very quickly. There is another term that you all really have to know as well, called borygmus. I think we also call it borygmy. This is the term you'll also hear about when you guys come to complex health. This is one of the vowel sounds you hear in the those patients who have dumping syndrome. And what this is hyperperistalsis. I mean, the peristalsis, or that increased motility, is greater than normal, greater than what you would ordinarily see. All right. And then, of course, you have your perfectly silent abdomen, which is uncommon, of course. Years ago, I thought that, again, you know how it is when you come into nursing, that you have all these different ideas about the different things that we do. So We used to hear that you have to listen to bowel sounds for 5 minutes, each quadrant. And when we used to say, we don't have enough time to be standing there for 5 minutes listening to each quadrant, which would have been 20 minutes, right? If you divide them into quadrants of four quadrants. And so, yeah, so that's a myth. And basically, well, a myth in terms of if obviously the bowel sounds are normal, then you're good. But if you think that there's silent, what we call a silent abdomen or no bowel sounds at all, before you make that judgment call, you should go ahead and listen for 5 minutes by your watch, of course, before you can report that there's an absence of a complete absence of bowel sounds. All right. And I think I told you that this information is found on page 541. If I didn't, excuse me, but forgive me for saying that again. All right. All right. Now, as we listen to our patients or we assess our patient's abdomen, we also have to be concerned about vascular sound. You guys know that within the stomach region, we have the large aorta that runs down through the abdomen. And arteries, associated with the kidneys and so forth. So um, when we listen to the abdomen, we have to note any vascular sounds or any bruits. When you think about a bruit, it sounds like a splashing a sound and whatnot. Now, there are a small fraction of folks out there that does have a bruit. Um, when we assess a patient for a bruit in terms of palpation, we have to use a more firmer pressure. And what we're doing is we're looking at the arteries of the aorta as well as the renal artery, the iliac, and the femoral arteries as well. And this is going to be especially important in those patients who have hypertension. Reason that is important is because if the blood pressure gets too high, if there's an aneurysm or weakness in the wall of these arteries, it can cause them to rupture. So we have to be really um, um, careful in our assessment of the abdomen and the vasculature. All right. Um, there was a time, and some of you, depending on how long you've been in healthcare, whenever we inserted an NG tube, we would do the syringe air test, and this is, of course, when we would take a large syringe. We would draw like 30 cc's of air and place our stethoscope over the stomach, and we would take the tip of the syringe and connect that to the NG tube, and then we would inject that air into the NG tube. And when we did that, we would hit this like whoosh kind of sound. Of course, we no longer actually do that. It's not evidence based. What we initially do is we get an X-ray when we initially when we insert the NG tube, we confirm placement by way of an X-ray. And then thereafter, if you ever have to insert or excuse me, administer or before you administer medications and water and so forth, what we have to do is we have to check the drainage from the NG tube. We can also withdraw some of the content from the abdomen, not a whole lot, and we use pH paper. And this tells us if you're in the stomach, because remember, the pH of hydrochloric acid is very low. Like I'm talking, let's say like one, maybe two, but that's pretty acidic. And it's so acidic. If you were to take hydrochloric acid and pour it onto some, let's say, piece of wood or whatever, you might see some burning, all right, because it is actually acid, real acid, believe it or not. Um, and so um, my students, they recognize that the nurses, before they gave the patient's medications, they were using the, the air method instead of the using the pH paper. So, I shouldn't assume, but well, let me just say that hopefully they did an initial, um, confirmation by doing a X-ray to determine where the NG tube was located. But any subsequent confirmations, if you will, it should be by pH paper and not by the air method. That probably made the nurses feel good, made them to think that, well, it's in the right place. Well, you don't want to do that because it may not be. And we live in an evidence-based practice era, and we have to do it the right way. So keep that in mind. Also, when we place an NG tube at the tip of the nose, where the tube is located, we actually take some tape and we wrap it around that area. All right. And when we do that, let's say, for example, the tape is right here once you inserted the NG tube. And then when you come back, I'm demonstrating this. I don't know if you all can see this on your end. But so then you come back in the room and you see that tape down here. Well, that means that NG tube has been pulled out a bit. Or if you notice that you can't see the tape at all, it may have migrated inward. And we also tape down the NG tubes as well on the nose. Um, Let's see. Now, usually there is no vascular sound that is present. However, about 40 to 20% of healthy people, usually not older than 40 years of age, may have a normal a bruit originating from the celiac artery. And so if we auscultate such a sound, we have to note its location, its pitch, and timing of the vascular sound. Now, if a patient has a systolic bruit and it is a pulsating, blowing sound, these occur because it's kind of stenosed. In other words, there's a narrowing of the artery. There's also a partial occlusion, or it can be an aneurysm of the artery. And that's why I said if a patient is hypertensive, you need to really make sure you keep their pressure well controlled, right? Um, All right. And you guys know that the auscultation method, as far as the NG tube is concerned, can incorrectly suggest that the NG tube is in the proper place, which is the stomach. And of course, if it's not in the stomach, let's say if that tube is actually in the lungs, it can be fatal to the patient because we might be administering tube feedings or some other material or medications into the lung, inducing an aspiration. All right. And so that won't be safe for the patient. All right. Now that was auscultation. Now we get into percussion and timpani. Um, so we percuss whenever we're percussing. We're talking about the more solid organs, such as the liver and the spleen as well. Again, when we're talking about percussion, excuse me. So in order to assess relative density of the abdomen, of abdominal contents, um, we have to also determine where what we're trying to determine where the organs are actually located. And of course, what we're trying to do is determine if there's any abnormal fluids or masses upon assessing these patients. Now, I will be honest with you, percussion don't use a whole lot anymore. I mean, you'll see perhaps some old school docs, they may do it every now and then, but it's just the results are highly unreliable, and so not actually recommended. All right. Now, when and by the way, this information can be found on page 542 to 43. So we first percuss lightly in all four quadrants to determine the prevailing amount of tympany and dullness. I kind of get a general overview, if you will. And take a look at figure 22.13 for that demonstration. We also move in a clockwise direction. Now, tympany should predominate because air in the intestines rises to the surface when the patient is in the supine position. And then, of course, dullness occurs over a distended bladder. It's dull because even though the bladder is a hollow organ, if it's full of urine, it becomes, or you would have a more of a dull sound. And of course, that's again when the bladder is full. Also, dullness can occur over adipose tissue if there's fluid, and also if there is a mass. All right. There's also hyper resonance that is present with gaseous distension, and so you will hear that hyper resonance, a sound, if you will, if there's a lot of gas in the abdomen. Now, traditionally, the upper and the lower borders of the liver were identified by percussion in order to estimate the size or the span, how much the liver actually spans. All right. Now, this technique of measuring the liver, the liver span, it actually underestimates the true size of the liver because clinicians typically place the upper border too low and or the lower border too high. The percussion also yields, as I mentioned, some variable results, and so it doesn't really tell us or identify whether or not the patient has hepatomegaly, and that's an enlargement of the liver. Doesn't tell us that when that is present, and so again, this is just not something that we really recommend a lot. And I'm not sure, because I'm not sure how you guys do it here for this course compared to when I taught this in another program. I'm not sure if this is something you will be doing in the lab, but I know I need to take a look at the assessment or the lab assessment forms to see if that's in there. Hopefully it's not, because as I said, it's not something that we do a whole lot anymore. So good to still know about it though, because, as a clinician, you may be one of those who does it every now and then, especially let's say, for example, if, you're assessing a patient who you're trying to determine if you should insert a Foley catheter in this patient. And so you want to know, of course, these days we use a bladder scan to determine if there is how much urine rather is in the bladder. But sometimes you may do an initial percussion just to see if the bladder sounds gives you a kind of a dull a sound, and that can sort of kind of tell you if the bladder is full. But of course, hopefully you are in a facility that does use a bladder scan. A pretty common device, by the way. All right. Um, all right. Now, here, when we're trying to determine kidney tenderness, this is an exam that we use. It's called we actually call it CB. The physician may describe it as CBA tenderness, but that's the acronym for a costal vertebral angle tenderness. All right, and there's an example in your book for you to take a look at. That is on around page 543. And of course, if there is tenderness, it does indicate inflammation of the kidney. All right. There's an indirect fist percussion that causes the tissues to vibrate instead of producing a sound. All right. There's more of a vibration. And to assess the kidney, we place one hand over the 12th rib at the costal vertebral angle on the back. All right. And let me just show you real quickly what that will look like. That's that clockwise kind of motion, different areas as you assess the arteries and the abdomen. No, this is the clockwise motion when you're checking for a tympani. But I wanted to show you the costal. Or here it is. So this is an indirect, as I mentioned, assessment. You feel like a thud, right? Or the person feels a person normally feels a thud, but there's no pain if it's a normal assessment. But they take the hand, they place it over the kidney, and they take the ulnar part of the hand, and they hit or they strike rather the hand. So that's more of an indirect um, uh, way of assessing this patient for CBA tenderness. So just make sure you guys take a look and always take a look at the corresponding side here where it says sharp pain occurs with inflammation of the kidney or nephric area as in pyelonephritis. And so you always want to know, all right, so I'm performing, this assessment, but what does it mean? And so you should know that. Just don't look at how to perform the assessment. You need to know, well, if I perform this assessment and it's positive, what is it actually saying? All right. And so that's what you want to do. All right. Now, as I mentioned, um, the thump, so we thump the hand that is over the kidney with the ulnar edge with our fist, this portion, not the radial, but the ulnar part. And a person normally feels a thud, as I said, and they don't actually feel any pain, which would be a negative result. Um, Now it is usual. It's a usual sequence rather in complete examination is with the thoracic assessment. In other words, while you are assessing the thoracic region, like your breath sounds and so forth, um, and the person is actually sitting up, you might as well go ahead and do the CBA. Or check for CBA tenderness as well. So remember I told you you don't want your patients moving in all sorts of positions, if you will, because it can wear patients out. It's like they're going through all these acrobatics, movements. Just make sure once you're assessing, like you're auscultating the breath sounds posteriorly, just go ahead and do stand behind the patient and do this assessment as well. It'll make their lives a whole lot easier. And again, take a look at page 543 for this information. Let's see. All right, go back here. All right, and hopefully you can see my PowerPoint again. I'm still sharing. All right, so as far as palpation of the abdomen region, we do palpate on the surface, and we also palpate the more deeper areas. And so when we're palpating, we're trying to judge the size, the location, and consistency of certain organs, spleen, liver, a kidney, and so forth. And what we're trying to feel for is if there are any masses or even tenderness. All right. Now, because most people are naturally inclined to protect the abdomen, especially if they think you're getting ready to strike the abdomen or you're getting ready to push down on it, we do need to think about certain relaxation measures to completely relax the muscles, because the muscles of the abdomen can appear hard, and especially in some of us, and can yield results, false positive results. So keep that in mind. Um, Now, we do begin with light palpation, and then we proceed with deep palpation. You don't want to start with deep palpation, and then the patient will start guarding, and they may not even allow you to examine them after that because it's just too tenderness. So always start off lightly, light to deep. Right now, that information is on page 543 to 544. I declare I don't know how we can actually get through this in one class setting, you know, especially when you want to spend um, a bit more time on some of this information. But anyway, all right. So as far as light and deep palpation that I just mentioned, so with either technique, we have to locate or note the location, the size, consistency, and of course mobility of any palpable organs, and of course the presence of any abnormal enlargement. Also, if there's tenderness and if a mass is present, and of course, the author of your textbook talks about how we have to make sense of what we're feeling, um, because it is more difficult than what it actually appears. All right. So we have to make sense of what we feel, because, of course, we're going to say, especially when we're inexperienced in doing these assessments, it all feels the same to me. I mean, I just feel like I'm just pushing into subcutaneous tissue. I don't feel any discrete or distinctive organs beneath my fingertips. So, um, and of course, as you get more experienced, then of course that language will hopefully change. All right. So it's just one of those things you just have to keep practicing. All right. Now, uh, we have to we talked about in class, or we will talk about in class, right? Um, because this lecture is before class. Anyway, so we have to think about the various organs that are located in each quadrant. All right, that's why we have to learn our anatomy and physiology. Because if, let's say, for example, you're assessing the right upper quadrant, is it the liver? Is it the gallbladder? Is it um, um, or whatever the different organs in that particular region. So we have to keep that in mind, and that would help us you have to visualize this, and of course memorize what is in those areas, which will give us an idea of what additional tests may be warranted. Say if I can feel, or if I think I feel the liver being enlarged, that would prompt the clinician to perhaps do a CT scan, maybe an MRI, X-ray, and what have you, to determine, if the liver is enlarged, for example. All right. Now, we have to also remember that some of the structures within the different quadrants are normally palpable. You can actually feel them. Um, if a patient has mild, so a mild tenderness normally is present when palpating the sigmoid colon, which would be the left lower quadrant, right? So there is usually some mild tenderness. So, and that would be a normal assessment finding. Any other tenderness, of course, should be investigated because it should not be tender. Um, Now, if you guys identify a mass, we have to first distinguish it from a normally palpable structure or an enlarged organ. And so we have to make some distinctions here. And of course, this information can be found on page 44 and 40 through 49. So take a look at that. With respect to identification of a mass, these are some of the things that we have to consider documenting upon our assessment. Um, if you identify mass, then this is what needs to be documented. We need to determine the location of it, the size, shape, consistency. That is, does it feel soft? Does it feel firm or hard? Also, as we're palpating, we want to know if it feels smooth or if it's nodular. Nodular is not good. All right. Mobility, including movement with respirations. So when the patient breathes, does it move? Pulsatility. Can you determine if there's a pulse present? And also, of course, if there is a tenderness present as well. And take a look at page 545 for additional information here. All right, and information from this slide is also on page 545. And all right, so we have to make sense of what we're feeling. Um, or I should say, rather, making sense what we're feeling is more difficult than what it actually looks. I mean, you have to really practice this stuff over a period of time, years perhaps, before we actually really get comfortable. Because again, as I said, it just feels like you're pushing into a cushion of fat, and we will, you hear the more younger clinicians say that, well, this all feels the same, so I don't, feel any difference. And so just a skill you just have to really perfect. Um, and as I also said, we have to memorize what is in each quadrant, and that'll give you an idea what you're possibly feeling. All right. For example, in the left, excuse me, yeah, the left lower quadrant, you're likely not going to feel, or let's say if you're percussing, you're not going to likely feel anything in the way of um, uh, dullness, mostly tympany, because the intestines are hollow organs. Of course, if there's a mass, then that's a different story. But it shouldn't be a dull kind of sound coming from that area. All right. And take a look at figure 2218, and this shows actually this is what I'm actually showing or presenting here now. Um, all right. All right. And the liver, of course, is also a part of the abdominal assessment. All right. So with this particular assessment, um, let's see. Let me see what this will look like. Um, all right. So I wanted to just show you an image of what palpating the liver will look like. And as you can see there, because you know that, well, this, first of all, is the right upper quadrant. We know that the liver is in this quadrant. And, see how you're supporting the liver with the left hand here. And then you're actually palpating, trying to feel the edges of the liver with that right hand. So just want to kind of give you an idea of what that would look like. All right. But as I talk about it, you can visualize it a whole lot better. All right. So there, actually, that's on the next slide. So again, so we place the left hand under a person's back, which is parallel to the left and 12th ribs, and lift up in order to support the abdominal contents. All right. And then we place the right hand on the right upper quadrant with the fingers parallel to the midline. All right. And you all saw how that is done. We push deeply down and under the right costal, the rib margin. And then we ask the patient to take a deep breath. And it is normal to feel the edge of the liver bump the fingertips as the diaphragm pushes it down during inhalation. So when the patient inhales, it does push the liver down a bit, and then you can feel those edges. If it now it should feel like a firm, regular ridge, but of course the normally the liver is not palpable, but you might feel it again during inspiration. There's also a hooking technique, which is an alternative method used to palpate the liver. I don't know if there's a image for that one as well. Example. All right, yeah, it is. So this is the hooking technique here. All right. And you can, of course, read this section here in terms of how to do that. Don't think you all actually doing that in the lab, but again, we still have to go over this because you never know what you might be testing on. What you may be testing on and what you're actually performing in the lab might be slightly different. But I still think it's important, of course, because you never know. You may use these techniques when you are assessing your patients in the hospital. Um, let's see. Now, except with a depressed diaphragm, the diaphragm that pushes down. When it pushes down, the liver can be palpated more than 1 to 2 centimeters um, below the right costal margin. Um, all right, and so we do have to record the number of centimeters it descends, and also note the consistency, whether it's hard or nodular. Nodular is not good. Also, there's tenderness, which is not good either. Um, so, for example, an abnormal firm liver can indicate that a patient has cirrhosis of the liver. All right. So again, the book actually provides you with some really great examples of how those assessments, those techniques should appear. All right. Now, in terms of assessing the span of the liver, um, sometimes if the abdomen is distended, if it's obese, or too tender for palpation, or if the muscles are rigid and guarded, another test we can do is referred to as the scratch test. All right. And I think there should be an image of that as well, the scratch test. Um, that's actually about the spleen. Maybe it doesn't have it, the scratch test. Yeah, it doesn't have an example, but anyway, we can always get the description of it. All right. All right. So um, the scratch test. So this may help us to define the border of the liver when the abdomen again is distended or the muscles, abdominal muscles are tense. And so what we do is we place the stethoscope over the liver itself, and with one fingernail we scratch with short strokes over the abdomen. And we start around the right lower quadrant of the abdomen, which is the same side, of course, is the liver, and moving progressively up towards the liver, because eventually that scratching will be over the surface of the liver. And what we're going to hear essentially is a distinctive change in sound, because you're over more solid organ, and you're over a more solid organ. In the right lower quadrant, you have a more that kind of hollow sound. But then, of course, once you move over that the liver, which is a more solid organ, again, it should change. All right. So when scratching, when the scratching sound in your stethoscope becomes magnified, you will have crossed the border from over hollow organs to a solid one. And that's what I just mentioned. So that's what we're basically doing. Um, let's see. That is that one. Right. And of course, now we are looking at the spleen. Um, all right. Now, so in terms of assessing the spleen, now the spleen is normally not palpable, and it must be enlarged about 3 times its size in order to be actually felt. Now, to search for it, you have to reach your left hand over the abdomen and behind the left side of the 11th and 12th rib. Um, and then, of course, we lift up for support, and then we place the right hand obliquely on the left upper quadrant with the fingers pointing towards the left axilla and just inferior or below the rib margin. And then, of course, you push your hand deeply down and under the left costal margin or rib, and then ask the person to take a deep breath. And you should feel nothing that is firm. And let me show you. This is what that will look like, right? Now, this patient is supine in a supine position, right? But then, of course, this is another method. When you have them kind of turn on this side a bit, another method to assess the liver excuse me, the spleen as well. Right. Um, let's see. And here again, just make sure you guys are taking a look at this information here, because when you're assessing the spleen, It can be, if it is enlarged, it can be mononucleosis, it can be trauma, leukemia, lymphomas, portal hypertension, and also an HIV infection. All right. Also consider malaria in persons with a fever and splenomegaly, especially if they are returning from travel where malaria is prevalent or endemic. Now, if you feel an enlarged spleen, uh, we refer the patient, we want to refer the patient for further, more sophisticated tools to assess these patients, because we don't want to continue to palpate an enlarged spleen, because an enlarged spleen is typically friable and can rupture very easily, and it's very vascular, by the way, and so your patients can actually bleed to death. So you don't want to over palpate this particular organ. We also describe the number of centimeters that it extends below the left costal margin as well. So remember, that is extremely important that you do not over palpate the liver, excuse me, I keep saying liver, the spleen in these patients. All right. Um, yeah, so I kind of talked about this one already before I got to it. Actually, I was reading from the book, but yeah, so pretty much the same thing here as well. So we're at 47 minutes now, so it looks like we're kind of moving along, which I'm really happy about. Um, yeah. All right, so let me, so right now we're going to look at the kidney, and I think it's always better for me to show you what that assessment would look like. Again, give you that visual, and then as we talk, or as I talk, you'll be able to see what that looks like. See, that's what that would look like. That's assessing the kidney on the right, and this is assessing the kidney on the left, right? So that would be the right kidney, and this would be the left kidney. I don't think the right is normally palpable. Normally the left is, but I don't think the right one is. And you're reading a book where it talks about your hand being placed together in a duckbill position, and this is what that duckbill looks like. You see that duckbill, this hand, the palm of this hand comes or touches the palm of the other hand, and we're basically trying to palpate the kidney here. That's what that would look like. All right, and you'll find this information on on page 548 to 49. All right. So as you can see in the image I just showed you, uh, searching for the right kidney, we search for the right kidney by placing the hands together in that duckbill position at the patient's right flank. All right, figure 22.22a. We press, and so press your hands, press your two hands together firmly. And of course, you need a deeper palpation than that used with the liver or the spleen. So your palpation is going to be deeper in this case. And then we ask the patient to take a deep breath. And most people, you will feel no change. All right. Occasionally, you may feel the lower pole of the right kidney as a round, smooth mass that slides between the fingers. And of course, either condition would be considered normal. In terms of the left kidney sits 1 centimeter higher than the right kidney, and well, I had it backwards. So it's the left kidney that is normally not palpable. All right, so the right kidney you can at least feel the pole, the lower pole of the right kidney, but the left is not normally palpable. Um, All right, and so then we search for it by reaching the left hand over or across the abdomen and behind the left flank in order for support. All right, and then let me get rid of this. And this is, of course, in figure 22.22b. Then we push the right hand deep into the abdomen. Remember, the palpation here must be deeper. And then we ask the patient to take a deep breath or to breathe deeply. And of course, there should be no changes felt or palpated upon inhalation. So that's how you would assess both of these, both left and right kidneys. Um, and then we are looking at the aorta, because remember the aorta is also a part of the abdominal assessment, and it's normally midline, of course, right? Or slightly midline, close to at least. And so let me see if this has one as well. Yeah, so that's how we assess the aorta there. That's your image, right? That's the image. All right. All right. So using your opposing thumb and fingers, um, we're palpating the aortic. We're looking for aortic pulsation in the upper abdomen, which is slightly to the left of the midline. So not exactly midline, but slightly to the left. All right. Normally, it is 2 to 5 to 4 centimeters wide in adults and pulsates in an anterior direction. All right. Um, all right. And then you also have this it's wide in presence of abdominal aortic aneurysm. If it's more wide, then you have to consider that we may be dealing with an aneurysm for this patient. This, of course, is on page 549. All right. So this is really important because you want to know, first of all, what is 2.5 to 4 centimeters. And then, of course, if there's anything that is greater than that, then again, we're thinking about an aortic, an abdominal aortic aneurysm, which is, can be very dangerous, especially when they rupture. Could be a major problem for this patient. All right, so we're getting back into some percussion here. Um, Now, there are times that we may suspect that the patient has ascites, which is free fluid in the peritoneal cavity. Normally, you see this in your cirrhosis patients. All right, because the liver produces proteins or albumin, and when of course the liver is impaired, it cannot produce albumin, and if it cannot produce albumin, then then fluids begin to leak out of the vascular space into the peritoneal cavity. Basically, albumin or these proteins are located within the vascular space in the veins, in the veins. And essentially, what happens is those proteins create what we call oncotic pressure. All right. And it is that oncotic pressure that keeps the liquid part of the blood within the vascular space. All right. Now, when the albumin levels are low, as in an impaired liver, also it can be due to the fact that someone is malnourished and they're not taking adequate proteins. But what happens here is the liquid part of the blood will begin to leak out because it doesn't contain that pressure to hold it within that vascular space or that first space. All right. Um, when someone does have ascites, the abdomen is typically distended. The flanks they bulge, and the umbilicus protrudes and is displaced downward. All right. Now, you can differentiate ascites from gaseous distension because sometimes the patient just has a lot of gas in the abdomen. So there's a couple of tests that we can perform. One is called the fluid wave test, which is on page 550, and the other is the shifting dullness test, which is also on page 550. Um, if someone does have ascites, not only can you see this condition in cirrhosis, but you can also see it in heart failure, portal hypertension, hepatitis, pancreatitis, and a cancer as well. All right. Um, and just go ahead and take a look at when you get an opportunity. Actually, you know what? Let me just go ahead and do that. So this is the fluid wave test here, right? This is a fluid wave test. That's the midline. And of course, you know, they're tapped both sides or whatnot. And you get to what you're looking at is the abdomen and how the fluids are moving back and forth. That'll tell you that the patient has ascites, right? So the fluid wave test, let's see, first test for fluid wave. So do the fluid wave test first by standing on the person's right side. Place the ulnar edge, see the ulnar edge um, of another examiner's hand or the patient's own hand um, firmly on the abdomen and the midline. So this is what we're talking about here, the ulnar part of the patient's hand. You'll place it here. This stops transmission across the skin of the upcoming tap. And then, of course, place your left hand on the patient's right flank with your right hand. Reach across the abdomen and give the left flank a firm strike. And again, that's when you'll see that fluid move in the abdomen. It says if ascites is present, the blow will generate a fluid wave. It will look like a wave through the abdomen, and you'll feel a distinct tap on the left hand. So it will tap that left hand over here. If the abdomen is distended from gas or adipose tissue, then there will be no change felt. So again, you're trying to determine if there's fluid in there or if there's just gas. All right. And then there's the shifting dullness test here, and this is what this would look like. Again, I don't think you guys are doing this, but um, you know, especially with this percussion, we're not really doing that a lot. But that's what that would look like. All right. Um, let's see. That's 79. All right. So that was dealing with ascites. Um, All right. So here we're going to be looking at tests that we can perform to determine if a patient is dealing with appendicitis. And of course, palpation is used mostly here. All right. Now, when a patient has rebound tenderness, we refer to that as Bloomberg's sign. And this is something you all really need to know because you will likely see it again. Now, we assess for rebound tenderness when the person reports abdominal pain or when you elicit tenderness during palpation. All right. Um, Right. So what we want to do is choose a site remote from the actual painful area. And We hold the hand at about a 90-degree or perpendicular to the abdomen. Then we push down slowly and deeply. All right. And then we lift up quickly. This makes structures that are indented by palpation rebound suddenly. All right. A normal or negative response, there would be no pain upon release of pressure. Now, we perform this test at the end of an examination because it can cause severe pain and muscle rigidity. And of course, if that happens, the patient is not going to let you assess them. So we do that last. Now, pain on release of pressure confirms rebound tenderness, which is a reliable sign of either peritoneal inflammation, or it also can be appendicitis as well. Or peritoneal inflammation, which is an inflammation of the peritoneal area of the stomach, can occur along with appendicitis at the same time. There's also an assessment called the inspiratory arrest or Murphy sign. This is also another term that is very important to know with appendicitis. So normally palpating the liver causes no pain. Now, in a person with inflammation of the gallbladder, for example, cholecystitis, pain can occur. So with this one, you hold your fingers under the liver border, all right, and then we ask the person to take a deep breath. Now, a normal response is to complete the deep breath without any pain. They would be able to fully breathe inward or inspiration, if you will, and they'll be able to complete that breath, and they just won't stop midway because the pain is so excruciating. You know, when we have abdominal pain, it's very difficult to breathe, of course, and so this is what we're trying to, which is abnormal, obviously, but that's what we're trying to figure out, is if this is the case with this patient. Now, when the test is positive, as the descending liver, you know, the liver is descending downward in the right lower quadrant, when it pushes against a gallbladder that is inflamed, then we know that you know this is a positive exam. The person feels that they will feel a sharp pain, and they will abruptly stop breathing upon inspiration midway, so they won't complete the breathing. All right. All of these tests are under other special tests for appendicitis we won't be looking at, but so we talked about the McBurney's. Is that the McBurney's? No, I'm sorry. So there's a McBurney's, a point tenderness. There's the ipsoasis muscle test, and I can show you what that looks like. So let's see. So these two would also actually be tests that you might see more so of. And let me see. So, all right, palpation. So this just shows you how to do these different tests, these examinations. Let's see, palpation. Yeah, the rebound tenderness here. So this is the inspiratory arrest or Murphy sign that we talked about and what it can mean. And then, of course, the McBurney's McBurney point tenderness. So we draw a straight line from the anterior superior spinous process of the ilium to the umbilicus. McBurney point is located 1.5 to 2 inches from the ilium along this line. And they give you, see, figure 22.16. 22.16. I don't see that at the moment. I don't want to click on it because it'll take me away from this page, but just take a look at figure 22.16 That's actually on page 545. Well, 545. Um, Got to get a little more familiar with this book again. All right. All right. So just make sure you go back. Just click on it. I'm kind of afraid to click on it because it'll take me away from where I am. But just take a look at that. And then this is the iliopsoas muscle test. Um, we perform this muscle test when the acute abdominal pain with the acute abdominal pain of appendicitis is suspected. So with the patient in the supine position, we lift the right leg straight up and flexing at the hip, as you can see here. Then we try to push down over the lower part of the right thigh as the person tries to hold the leg up. When the test is negative, the person feels no pain. All right. Now, when this test is performed, when this muscle rather is inflamed, again, which can occur with an inflamed or perforated appendix, pain will be felt in the right lower quadrant, and so this test, of course, would be positive. Right, and you can see how they perform this test as well. All right, and this is this Mantrell's score test. Don't think I've actually seen this one done in the hospital. Uh, yeah, don't think I've seen that much done. All right. All right. Now, in terms of infants, don't think you guys have had pediatrics yet. Some of this I'm pretty sure you will learn there, but we'll still go through it because according to some I've spoken with, they still go over infants. And so, of course, I'm not as comfortable with infants, but there are some pretty general things that, you should know about them that I think is important. And it'll help you, of course, when you do your rotation, when you're assessing your infants. Um, let's see. So this is more of inspection of the infant's abdomen. And so we have to think about the contour of the abdomen, which is more protuberant because of immature abdominal musculature. That's why you see that protuberant abdomen in these babies. Right. We also want to inspect the umbilical cord throughout the neonatal period. When the baby is born or the infant is born, the umbilical cord is white, and it does contain two umbilical arteries, and it should be one vein. So a total of three. You should see three blood vessels, and this is surrounded by mucoid connective tissue, and we call that Wharton's jelly. All right. Now, the umbilical stump, it does dry within a week. It gets hard, and then it falls off within about 10 to 14 days. Um, and skin covers the area for about 3 to 4 weeks. Um, and you can see that on page 552 for any additional information. All right. All right. So continuing with inspection. Right. So as we look at the baby's abdomen, it should be symmetrical, although two bulges is common. Um, what we may note an umbilical hernia with these babies, and it appears at 2 to 3 weeks, especially, and it is especially prominent when the infant cries. All right. It does reach the maximum size at about 1 month, up to about 2.5 centimeters to about 1 inch, but usually disappears by the first year. Now, another common variation is called diastasis recti. Diastasis. I was looking at that wrong. Diastasis recti. And this is a separation of the rectus muscles with a visible bulge along the midline. You'll see this mostly in Black infants, and it usually disappears by early childhood. All right. And also, they are abdominal breathers, so that abdomen shows respiratory movement. So that is what you will see in these babies. Now, the presence of only one artery does or can signal the risk of congenital defect. So if you only see one artery, then that's what you need to be thinking, and of course, working up. It can also signify inflammation. And then, of course, you also have this drainage after the cord falls off. And so that would be an abnormal finding as well that should be reported. And that can be seen on page 552 as well. Right. Now, as far as auscultation, auscultation yields only vowel sounds. You may hear this metallic tinkling, peristalsis in the infant, but no vascular sounds should be heard. As far as percussion, timpani over the stomach, of course, because it's a hollow organ, and dullness should be heard over the liver. As far as palpation is concerned, the liver fills pretty much the entire right upper quadrant. And normally you may be able to feel the spleen on the left side, both the kidneys as well as the bladder. Um, um, right now, this would be easily palpated. Well, the cecum, I'm sorry, the cecum is easily palpated in the right lower quadrant, as well as the sigmoid colon. All right. We also have to make sure that we note when the baby has the first meconium stool. All right. And this is, as far as the character, is a sticky, greenish, black meconium stool within 24 hours of birth. All right. And by the fourth day, the stools of a baby who is breastfed are golden yellow. It's pasty, and it smells like sour milk. All right. Of course, when a baby is fed by formula milk, then the stools would be brown, yellow. It's firmer and a more fecal smelling as well. And that's very important for you, especially once you get into um, pediatrics. That meconium stool, very important. All right, and then as far as developmental competence, how our infants or these children, they develop over time. So under the age of 4 years, the abdomen looks protuberant when the child is both in the supine position as well as standing. After the 4 years of age, then you'll see this characteristic pot belly, and it remains when standing because of lumbar lordosis. Has to do with the spine not being as developed. But the abdomen looks flat when the baby, or excuse me, the child is in a supine position. As far as the liver is concerned, it remains easily palpable, 1 to 2 centimeters below the right costal margin, and the edge is soft and sharp, and moves easily. Use of objective signs to aid assessment. Um, so basically, we have to look at other signs because the baby, sometimes the children, they can't articulate what is actually going on with them, and so we have to depend on objective signs. And so when the child starts crying, and the cry is uh, it changes in pitch as you palpate these organs, or if there's like facial grimacing, um, or if they're trying to get away from you, or they're guarding, then you know that there's an issue with that organ. But we have to depend on more visual of the objective findings here in this case. Again, they can't articulate what is happening to them all the time. Now, school age child has a slim abdominal shape as he or she loses the pot belly. But this slimming trend continues into adulthood. Now, adolescents, they become easily embarrassed with exposure of the stomach, and so we have to adequately drape them as necessary, right? And this information, of course, can be found on page 554. You guys really don't have a whole lot of readings, believe it or not. I mean, you know how it is when you have certain books and the reading is just you have all these words on like two columns of words on each page. But in this case, you have like a description of things, and then you have a little section over to the right that tells you about the abnormalities, if you will. But it's just not a whole lot of content um, in these books. So hopefully you'll find the reading very helpful, of course. All right. And then, of course, we always want to look at our aging adults, which is who you will likely be taking care of most of the time, especially if you work with adults. Um, Right. So as far as inspecting, you may note increased deposits of subcutaneous fat on the abdomen and hips because it is redistributed away from the extremities to, again, the abdomen and hips. Right. Abdominal musculature, of course, is now thinner as you get older, and it also has less muscle tone than, of course, compared to a younger adult. So, in the absence of obesity, you may be able to determine that the patient has peristalsis. Right. Now, because of thinner, softer abdominal wall, organs may be easier to palpate in the absence of obesity. Obesity with all the subcutaneous tissue would just make it more challenging. Now, the liver and the kidneys are also easier to palpate. So, with distended lungs and depressed diaphragm, the liver can be palpated lower, and it will descend below the costal margin at about 1 to 2 centimeters when the patient inhales. All right. So think about the lungs expanding, and then the diaphragm, it pushes structures down, and it can push the liver down as well, and it should be palpable in these cases. Now, when the abdomen is rigid, um, you will see less abdominal rigidity with an acute abdominal condition in those who are or the aged. Right. Now, with an acute abdomen, the aging person often complains of less pain than a younger person would. And so we can't assume that there's nothing wrong just because the patient doesn't express, that there's significant pain. So we still have to do our due diligence and do a thorough assessment on these patients because they just don't complain as much. And take a look at page 554 for this additional information. All right. And then take a look at these abnormal findings, abdominal distension. It can be due to obesity, air or gas, ascites, ovarian cysts, obviously pregnancy, feces, as in constipation, as well as a tumor. All right. Take a look also at page overview page 558 to 59, and how to it will show you how we inspect, we auscultate, percuss, and also palpate in order to assess these abdominal abnormalities, how we can determine what is a normal versus abnormal. And your book gives you a pretty great description. I think that might be in table 22.1. Let me see if I can bring that up. So I really like the way they laid this out. Let's see. Motion. It's kind of down here a bit. Yeah, like so, for example, let's go over here. So if there's air or gas, so as far as inspection, a single round curve, all right? Now, when you auscultate, depending on the cause of gas, can be decreased or absent bowel sounds with an ileus, because with an ileus, you know, those intestines are not moving, all right? Hyperactive with early intestinal obstruction. So before the patient has the intestinal obstruction actually fully develops, you'll hear the hyperactive bowel sounds. And of course, you know, when you have an obstruction, you can't move that air or the gas. As far as percussion, you hear tympany over a large area because there's a lot of air in those hollow organs. And as far as palpation, may have muscle spasm of the abdominal wall. You know, all that pressure is pushing against the abdominal wall. So I really like the way they did this. Take a look at this one as far as ascites is concerned. A single curve, everted umbilicus. The flanks are bulging. Let's see. Yeah, the flanks are bulging. When the patient is in a supine position, the skin is taut, glistening skin due to a recent weight gain. There's also an increase in abdominal girth. So this is what you'll be able to visualize. When you auscultate, normal breath sounds over the intestines, but diminished over acetic fluid. Excuse me. As far as percussion, tympany at top where the intestines float, dull, of course, over fluid, right? And then produces a fluid wave and shifting dullness. And so that's the test that you will perform. As far as palpation, the skin is taut skin, increase intra-abdominal pressure, limit palpation. And so it kind of gives you, you know, just kind of read through it. Yeah, just kind of read through it. So this is what that will look like. Well, over here. All right, this corresponds with this. All right. All right, we are getting there, I promise you. We're actually on slide 47. So this actually went a little faster than I thought. Common sites of referred abdominal pain. This is going to be very helpful for you guys because, you know, oftentimes when we're assessing patients, we think that the pain should be exactly where what we are inspecting. So we'll palpate, let's say, the pancreatic area. You know, we think that the pain should come directly from that area. But sometimes it's referred, and you may find it in the mid-scapula area instead, right? Now, there's an image on page 562 that shows you what organs are impacted with referred pain. So, for example, again, well, this is a different example. If a person has an ulcer, all right, a stomach ulcer, the pain can actually be felt in the shoulder instead of the stomach or abdomen, right? Now, when a person gives a history of abdominal pain, the pain's location may not be necessarily directly over the organ involved. And so keep that in mind because the human brain has no felt image of internal organs. So the brain can't determine, in other words, where um, the organ is situated. All right. Now, uh, uh, now this pain is referred to a site where the organs was located in the fetal development. So remember, when that fetus was inside of the mother, those organs were more or less pushed together, right? And so they didn't descend like, the abdominal structures descend into the abdomen, and of course, the lungs there in their designated areas and so forth. Where in infancy, or while the baby is a fetus, if you will, they're more compressed together. And of course, the brain just cannot decipher or determine where those organs are. All right. So these organs, they will migrate, during fetal development, and its nerves will persist in referring sensations from that former location. So wherever that organ was during fetal development, then, well, if it was near those areas, that's where the the brain will more or less pick up where that sensation is coming from. So it's kind of a weird thing, but just realize that just because, as you can see here, just because, um, well, some of these at least, the pain will be felt in other areas. This is a distinctive one here, like the pancreas. Um, Like the esophagus is found behind the lower sternum, the ulcer, particularly of the stomach, is referred to the shoulder, and so forth and so on. So it's not exactly where you would think it would be. All right. So if you see something written in the physician's note that the patient is having scapular pain, and then all of a sudden they're talking about pancreatitis, then you're thinking, well, how can that be? I mean, we're talking about the scapula, not the stomach. Again, referred pain is where those structures in fetal development was, at a certain point in time, no longer there, but the brain cannot make that determination. Hopefully that makes some sense, right? And then some other or additional abnormal findings, excuse me, one of two. So we're looking here at inspection, which is on page 552. Take a look at that. Take a look at umbilical hernias, epigastric hernias, incisional hernias, and also diastasis recti. So take a look at what that would look like. There's also a table, 22.4 and 22.5. Look at that for additional information. And also, or I went too fast, take a look at the abnormal bowel sounds, the succussion, a splash, the marked peristalsis, hypo, as well as hyperactive bowel sounds. Remember this term, borborygmi, which is hyperactive bowel sounds. So make sure you take a look at that. Um, and as far as vascular sounds or friction rub, you have the peritoneal friction rub, arterial bruit, as well as a venous hum. All right. And of course, on palpation of enlarged organs, that involves the liver, um, the gallbladder, spleen, kidney, and also considering an aortic aneurysm as well. And that's on page 552. I did provide that information. Um, so read about what are the possible health issues with an abnormal assessment finding. That's what you will take note of in these sections. And the last one. All right. This is just a summary checklist of the abdomen examination that you will perform. As far as inspection, we're looking at the contour of the abdomen. Is there symmetry? We also look at the umbilicus. What does the scan look like? Is there any pulsations or movement? What about hair distribution and also demeanor of your patient? All right, do they look like they're in pain? Do they look miserable, if you will? And then, of course, as far as auscultation, and of course, this is the order, as you know, inspection, auscultation, percussion rather, and then palpation, that order. As far as auscultation, vowel sounds, and also note any vascular sounds as well. And then you have your percussion, all four quadrants and borders of the liver, as well as the spleen. This is just giving us that summation, right? And as far as palpation, light and deep palpation in all four quadrants, and also we're palpating the liver and the spleen as well. Don't do a whole lot of percussion anymore, as I mentioned, but obviously palpation is going to be very important here. So that is about it, and thankfully we're at about an hour and 30 minutes, and so I won't feel as rushed when I'm talking to you guys tomorrow in class about well, actually, the abdominal lecture will be next Wednesday. Yeah, next Wednesday. And of course, the peripheral vascular assessment will be on this Wednesday or tomorrow. All right. So that's about it. I appreciate you guys taking a look at this presentation. Let me go ahead and stop sharing. And let me know if you all have any questions, and I'll try to help you as much as possible. And I think that's about it. I don't have anything else. We'll see you guys shortly. Thank you.